Welcome to today's lecture on endocrinology, specifically focusing on thyroid hormone synthesis and secretion. In this comprehensive script, we will explore various topics related to the thyroid gland, including TSH and thyroid hormone feedback regulation, Graves' disease, subclinical thyroid dysfunction, thyroid autoantibodies, thyroglobulin, thyrotoxicosis, pediatric thyroid disorders, radioactive iodine uptake, RAIU, testing, fine needle aspiration, FNA, cytology, and thyroid function tests in pregnancy. We will conclude with a summary of the key points discussed. The thyroid gland plays a crucial role in the production and release of thyroid hormones. Thyroxine, T4, and triiodothyronine, T3, are the two primary hormones secreted by the thyroid gland. The synthesis of these hormones begins with the uptake of iodine from the bloodstream by thyroid follicular cells. Iodine is then combined with the amino acid tyrosine to form thyroglobulin, a precursor protein. Inside the follicular cells, thyroglobulin undergoes a series of enzymatic reactions to produce T4 and a smaller amount of T3. Once synthesized, T4 and T3 are stored in the colloid-filled follicles within the gland. Upon stimulation by thyroid-stimulating hormone, TSH, released from the pituitary gland, thyroglobulin is taken up by the follicular cells via receptor-mediated endocytosis. Next, within the follicular cells, thyroglobulin is enzymatically cleaved to release T4 and T3 from its structure. These thyroid hormones are then secreted into the bloodstream, where they exert their physiological effects on various target tissues. The secretion of thyroid hormones is tightly regulated by a negative feedback loop involving the hypothalamus, pituitary gland, and thyroid gland. The hypothalamus releases thyrotropin-releasing hormone, TRH, which stimulates the pituitary gland to release TSH. TSH, in turn, acts on the thyroid gland to stimulate the synthesis and secretion of T4 and T3. When circulating levels of T4 and T3 are adequate, they exert inhibitory effects on the hypothalamus and pituitary gland, reducing the release of TRH and TSH, respectively. This negative feedback system ensures that thyroid hormone levels remain within a narrow physiological range. Any disruption in this feedback loop can lead to alterations in thyroid hormone production and subsequent dysfunction. While most of the thyroid hormones in circulation are bound to transport proteins, a small fraction exists as free, unbound hormones. Free thyroxine, FT4, and triiodothyronine, FT3, are the biologically active forms that can freely enter target cells and exert their effects. Measuring FT4 and FT3 levels is crucial in assessing thyroid function as they provide a more accurate representation of the active hormone availability. Various laboratory tests, such as radioimmunoassays or chemiluminescent immunoassays, can quantify these free hormone levels. Low FT4 and FT3 levels may indicate hypothyroidism, whereas elevated levels can suggest hyperthyroidism. Interpretation of these results requires careful consideration of the clinical context and correlation with other thyroid function tests. Graves' disease is an autoimmune disorder characterized by the production of autoantibodies against the TSH receptor. These autoantibodies, known as thyroid-stimulating immunoglobulins, TSIs, mimic the action of TSH on the thyroid gland. TSIs bind to the TSH receptor, leading to the overproduction of T4 and T3. This excessive thyroid hormone secretion leads to symptoms such as weight loss, palpitations, tremors, heat intolerance, and goiter. Treatment strategies for Graves' disease include antithyroid medications, radioactive iodine therapy, and thyroidectomy, depending on the severity and individual patient factors. Subclinical thyroid dysfunction refers to abnormalities in thyroid function tests without apparent clinical signs or symptoms. It encompasses subclinical hypothyroidism and subclinical hyperthyroidism. Subclinical hypothyroidism is characterized by elevated serum thyroid-stimulating hormone, TSH, levels with normal free thyroxine, FT4, levels. Although patients may be asymptomatic, they have an increased risk of developing overt hypothyroidism in the future. Conversely, subclinical hyperthyroidism is characterized by low or undetectable TSH levels with normal FT4 levels. As with subclinical hypothyroidism, patients may remain asymptomatic, but monitoring is required to detect potential progression to overt hyperthyroidism. Thyroid autoantibodies are antibodies produced by the immune system that target components of the thyroid gland. The most commonly detected thyroid autoantibodies include thyroid peroxidase antibodies, TPOAB, thyroglobulin antibodies, TGAB, and thyroid-stimulating immunoglobulins, TSIs. POAB and TGAB are commonly found in autoimmune thyroid disorders such as Hashimoto's thyroiditis and Graves' disease. Their presence can help in diagnosing these conditions and assessing the risk of future thyroid dysfunction. TSIs, as mentioned earlier, are the autoantibodies responsible for stimulating thyroid hormone production in Graves' disease. Detection of TSIs aids in the diagnosis and monitoring of this condition. Thyroglobulin is a glycoprotein produced by the thyroid follicular cells and serves as a storage form of thyroid hormones within the colloid-filled follicles. Measurement of thyroglobulin levels is useful in various clinical settings. It can help assess the effectiveness of thyroid cancer treatment, as thyroglobulin levels should decrease after surgical removal or radioactive iodine therapy. Additionally, thyroglobulin levels can assist in detecting the recurrence or metastasis of thyroid cancer, especially in patients who have undergone thyroidectomy. Thyrotoxicosis refers to a clinical state characterized by elevated levels of thyroid hormones in the bloodstream and the resulting manifestations of excessive thyroid hormone action. It encompasses a spectrum of conditions, including Graves' disease, toxic multinodular goiter, and toxic adenoma. Symptoms commonly observed in thyrotoxicosis include weight loss, heat intolerance, sweating, tremors, palpitations, and mood disturbances. Prompt identification and management of thyrotoxicosis are essential to prevent complications such as cardiac arrhythmias, osteoporosis, and thyroid storm, a severe and potentially life-threatening condition. Thyroid disorders can affect individuals of all ages, including pediatric populations. Congenital hypothyroidism, the most common thyroid disorder in newborns, necessitates early detection and treatment to prevent adverse neurodevelopmental outcomes. Other pediatric thyroid disorders include autoimmune thyroiditis, thyroid nodules, and thyroid cancer. Close monitoring and appropriate intervention are crucial to ensure optimal thyroid function and normal growth and development in children. Radioactive iodine uptake, RAIU, testing is a diagnostic procedure used to evaluate various thyroid conditions. It measures the amount of radioactive iodine that the thyroid gland takes up from the bloodstream. RAIU testing can help differentiate between different causes of hyperthyroidism. In Graves' disease, RAIU is typically increased due to the overactive thyroid gland and elevated TSH receptor stimulation. In contrast, toxic multinodular goiter or toxic adenoma shows focal areas of increased iodine uptake corresponding to the autonomously functioning nodules. This information aids in the selection of appropriate treatment options for hyperthyroidism. Fine needle aspiration, FNA, cytology is a minimally invasive procedure performed to evaluate thyroid nodules for the presence of malignancy. During FNA, a thin needle is inserted into the nodule, and cells are aspirated for cytological assessment. These cells are then examined under a microscope to determine if they are benign or malignant. FNA cytology has become the gold standard for preoperative evaluation of thyroid nodules, aiding in the early detection of thyroid cancer and guiding appropriate surgical management. Thyroid function tests play a crucial role in assessing thyroid health during pregnancy. Pregnancy involves significant changes in thyroid hormone requirements, largely influenced by the production of human chorionic gonadotropin, HCG, by the placenta. Measurement of thyroid-stimulating hormone, TSH, and free thyroxine, FT4, levels is vital in diagnosing and managing thyroid dysfunction during pregnancy, especially subclinical hypothyroidism. Untreated thyroid dysfunction in pregnancy can lead to adverse maternal and fetal outcomes, including increased risk of miscarriage, preterm birth, preeclampsia, and neurodevelopmental impairments in the offspring. In conclusion, the thyroid gland and its associated hormone synthesis, regulation, and disorders form a crucial aspect of endocrinology. Understanding the intricacies of thyroid hormone production, the feedback regulation system, and various thyroid disorders is essential for medical practitioners. We have explored topics such as Graves' disease, subclinical thyroid dysfunction, thyroid autoantibodies, thyroglobulin, thyrotoxicosis, pediatric thyroid disorders, radioactive iodine uptake, RAIU, testing, fine needle aspiration, FNA, cytology, and thyroid function tests in pregnancy. By delving into these topics, we have gained a comprehensive understanding of the pathophysiology, diagnosis, and management of thyroid-related conditions. It is important to continue learning and staying updated on advancements in this field to provide optimal care to patients with thyroid disorders.